Hi, my name is Karina Demchuk. I'm Dr. Michael Orlow's research assistant. I work in the cardiology department at Stewart St. Elizabeth's Medical Center, and today I will be discussing right-sided versus left-sided left bundle area lead implants. Before jumping into my project, I'd like to take a moment to familiarize you with conduction system pacing. This is a technique that involves implanting permanent pacing leads along different sites of the cardiac conduction system, which is outlined with my highlighter here. Conduction system pacing has been rapidly gaining popularity for treating patients with symptomatic bradycardia and for patients requiring cardiac resynchronization therapy. His bundle pacing is an older pacing technique, which is now replaced with left bundle area pacing. Left bundle area pacing is a much more popular technique now because of its high success rates. The left bundle area is a wide target site which allows for direct pacing capture, resulting in a narrow QRS. The resulting pacing parameters with left bundle area pacing is consistent throughout, unlike the His bundle pacing where there are rises in the threshold. Typically, His bundle pacing and left bundle area pacing are performed via the left-sided approach, meaning the pacemaker or ICD is implanted on the patient's left side. There is one study that reported a right-sided approach for His bundle pacing. This study explained that their operators made modifications during the procedure to access the target site. However, even with these modifications, acute lead dislodgements still occurred. Therefore, it was concluded that using a right-sided approach for His bundle pacing is challenging. For left bundle area pacing, there was only one case report that talked about the anatomically complex case that resulted in operators using a right-sided approach for a left bundle area pacing procedure. In their report, they mentioned modifying a tool during the procedure. Besides this case report, there are no other bigger studies that talk about the success rate of the right-sided access for left bundle area pacing. Now this is where my project comes into play. My study team wanted to explore the feasibility and safety of right-sided implants and compare them to left-sided ones. We wanted to observe any differences in techniques when it came to the procedure. We also wanted to compare the pacing parameters acutely and chronically and see if there are any differences between the two groups. While this is a retrospective study, I would still like to quickly go over the implantation process for left bundle area pacing procedures. To start off, the operator would meet with the patient and confirm a right-sided or left-sided approach. Typically, left bundle area pacing procedures are left-sided, but if there's an indication for the other access, then that would be discussed between the patient and operator. For example, if a patient is left-handed, they would most likely have the implant on the right side, so it wouldn't interfere with their dominant side. Next, during the procedure, the operator would obtain venous access from the left or right side. So for example, this is from the left side, me pointing with my cursor, and now this is from the right side. With the Medtronic 3830 pacing lead in the delivery sheath, the lead would be maneuvered towards the right ventricle septum from the venous access. And while the operator is doing this, they are looking for the best spot to place the lead in the septum. There's pacing from the tip and from the ring, which helps the operator monitor the lead progression and the depth within the septum. Finally, before closing the patient, contrast is injected to confirm the location and depth of the lead. This was done for most cases in the beginning. However, later when operators became more familiar with this procedure, they monitored the impedance to check the depth of the lead instead of using contrast. During the study, 245 consecutive patients underwent left bundle area pacing procedures between October 2019 and December 2021. Procedural and pacing characteristics and electrophysiology parameters were extracted from medical records. This data was compared between the right-sided and left-sided access. Anatomical implant failure was defined by the inability to advance the lead into the septum, and electrophysiologic failure was defined as QRS over 130 milliseconds and or left ventricular activation time over 90 seconds. If either one of these failures occurred, that meant that the patient did not have a successful left bundle area pacing procedure. After analyzing the data, we saw that 31 patients had right-sided implants and 214 patients had left-sided implants. Procedural and pacing characteristics between the two groups were comparable and excellent. Both groups had high success rates for left bundle area pacing. During the procedures, none of the right-sided group patients had acute lead dislodgement, while 5 of the 214 patients had acute lead dislodgements within the left-sided group. No other procedural complications were found in either group. Overall, the right-sided and left-sided approaches resulted in very similar outcomes. The anatomic failure was rare for both groups, and electrophysiological failure was comparable between the two groups and low, which meant that left bundle area pacing was successful for a majority of the study cohort. When you look at the procedural and pacing characteristics down below, you can see that they are also very similar. It is important to note that ventricular activation time is a common parameter that is used to confirm capture of conduction system pacing. So if the number from the right-sided group is close to or similar to the left-sided group, that means that the procedures went fairly well. This figure shows the x-rays and angiograms of one patient from the left-sided group and one patient from the right-sided group. As you can see, the left-sided patient has their pacemaker on the left, and the right-sided patient has their pacemaker on the right. When you take a closer look at the angiograms, you can't really tell what side the pacemaker is on, but what you can see is how deep the lead is. So the red arrow is pointing to the contrast that was injected, showing the septum, and this darker part of the lead here is showing how much of the lead is within the septum, and the same thing goes for here. Overall, the follow-up data had no differences, which confirmed that both approaches had the same pacing success and had very low lead complications that followed the initial procedure. In conclusion, the right-sided approach to left bundle area pacing procedures is highly successful and comparable to the left-sided approach. There was no sheath modification that was necessary for the right-sided approach, and acute and chronic pacing characteristics between both anatomical approaches were similar. Before ending, I would like to say thank you to all the medical staff at St. Elizabeth's for making this retrospective study possible. Also, I would like to thank CTSI for the opportunity to present our work here today. If you have any questions, please feel free to email me at karina.demchuk@steward.org. Thank you all for listening. Bye!